died because of weather problems in Canada. So I'm going to talk about paroxysmal movement disorders, mainly paroxysmal diskinesias, which means episodic involuntary movements. These are my disclosures, and here the syndrome of episodic falling in cavaliers. They know the gene mutation for it too. But exactly how it happens is not clear. But paroxysmal dyskinesias occur in dogs, other animals as well. And this extreme stiffness during these episodes, often more in the hind limbs, the back arching, and then, and it's not myotonia. There's also well-known myotonia in goats. This is another animal with hyperkalemic rheatic paralysis. What you do is you infuse potassium and the horse slumps to the ground. It's a channelopathy. And it's possible that paroxysmal movement disorders like migraine and some seizure types may actually be a disorder of the ion channels, but it's not 100% yet. These ion channels are proteinaceous channels in the phospholipid membrane layer, and they're very important in maintaining neuronal excitability and maintaining order in the CNS. But any disruption here could lead to a variety of problems, peripheral as well as central. So paroxysmal movement disorders include dyskinesias, primary and secondary to a known disease, episodic ataxias, which are, there's 7 types now, but we mostly talk about 2, EA1, episodic ataxia 1 and 2. There's a curious entity called alternating hemiplegia of childhood, which is a genetic disorder, paroxysmal tremor, and then in children you have paroxysmal torticollis of infancy. But we are going to focus mainly on the paroxysmal dyskinesias. This is a very heterogeneous group. The common thread that binds them is the abrupt onset of involuntary movements out of a background of normal motor behavior. So, if you have a primary paroxysmal dyskinesia, the exam in between the attacks is normal. But if you have secondary to a disease, the interictal exam may be abnormal. And I'll show you examples of both. Now, many times these attacks are not seen by the doctor. Family comes and describes it, and rather than giving it precise names like paroxysmal dystonia, paroxysmal paroxysmal we say let's just call it with the generic term dyskinesia, which includes all the above movements. Okay? Now this situation is obviously changing because of iPhones, and Galaxy, and whatever, because everybody's bringing videos now. So we definitely will be able to see more and more of the paroxysmal dyskinesias on videotapes. By convention, the following 4 are not considered paroxysmal dyskinesia. We saw action, task-specific tremor or dystonia. It only occurs in between in attacks when you do something, but we don't call it paroxysmal dyskinesia. Tics can occur in bursts, and then patients stop having tics for extended period of time, but it's not called paroxysmal dyskinesia. Patients who have tremor can get suddenly worse when they're anxious or when they receive a drug that exacerbates tremor. We do not call that paroxysmal dyskinesia. We saw a great example of action-intention myoclonus in a post-anoxic patient with Lance-Adams syndrome. That's action myoclonus. We don't call it paroxysmal dyskinesia. Okay, so these things are not paroxysmal dyskinesias. There are 4 kinds of paroxysmal dyskinesias. One of the groups is debated, but I'll mention it. One is paroxysmal kinesigenic dyskinesia. You saw an example of this young man running and developing abnormal movements. There is non-kinesiogenic, where the precipitating event is not sudden movement, but it is caffeine, lack of sleep, alcohol, and these are different than the kinesiogenic one. The one that's debatable is the hypnogenic, or during sleep, but I'll mention it again in a second. And then lastly, paroxysmal exertional or exercise-induced dyskinesia, which is brought on by prolonged movement. So PKD is brought out by sudden movement or startle. PNKD, no, that's movement is not the precipitating factor. And the exertional one is the prolonged exercise, like on a treadmill, riding a bike, or running. We'll see examples of all those. Now, kinesiogenic dyskinesia occurs with sudden movement. Here is this young man with an attack in the right arm that spreads a little bit to the left. It's often asymmetric. There's no pain during the attacks. And as quickly as the attack comes, it disappears. Now it's both sides. It can be unilateral, bilateral, it can alternate sides. Each attack is short-lasting, but they are so frequent that they can be very disabling. If you have 100 attacks in a day, it becomes a pain in the neck, and you have to treat it. Most patients have dystonia, and I showed you 2 examples of that already. The one thing is you have to meet all the following criteria to label somebody as a primary or familial, idiopathic, whatever, paroxysmal kinesiogenic dyskinesia. It's often familial, it's got a genetic basis. But clinically, you should have identified kinesiogenic triggers, sudden movement, startle, even change in speed. You're walking slow, you start to run, you can have it right then. Attacks are short. There is no pain or loss of consciousness during those attacks. Remember these 2 things. Loss of consciousness would suggest a seizure, movement-induced seizure. Pain usually indicates a secondary type paroxysmal dyskinesia. You have to examine these patients. They should be totally normal in between the attacks. If you give them low-dose carbamazepine or phenytoin, they should respond dramatically. Now, if they haven't responded, you should doubt the diagnosis. And the age of onset is between 1 and 20 years. So if we start having paroxysmal kinesiogenic dyskinesia at the age of 60 years of age, it is not PKD. I showed you example of the facial-brachial dystonic seizure in a man with potassium channel LGI1 antibody. At that age, even if it started off as when he started to move, you should never label them as idiopathic primary paroxysmal kinesiogenic dyskinesia. If you do so, it be at your own peril. This man, I